There we go. This is the monoclonal antibodies were something that came up mostly distributed and allocated by the hospitals, but very much a sort of public health thing. And so it's kind of an interesting situation, and I think in our pandemic. Let's see, so there's our objectives here. So we're going to talk about some complex situations, competing tensions of public health. And obviously, I'm not a public health professional. I'm a nurse by clinical background and then a clinical ethicist here. So forgive me if I misrepresent some of the public health ethics. And then we're going to look at the ethical tensions and the importance of meeting the ethic of trustworthiness. So just a quick brief overview for those who don't know, monoclonal antibodies are laboratory made, and they're made to mimic or enhance the body's response to well, in this case, a viral illness. And so it's a viral protein that's exposed to white blood cells, which is then cloned to mass produce antibodies. There is some use of this in cancers, for which I know nothing about, but I found that interesting because I did not know that. I guess thinking back, I had heard of that. It requires an IV infusion, and for COVID, we're using it so it's going to be used for the EUA, which I'll show later. Anybody 12 and up who has a positive COVID test and is symptomatic with an onset within the last 10 days and not hospitalized. And the goal of this, right, is sort of a broad public health goal and an individual one. But the complex situation that we presented with was this, is that children's hospitals I got kicked out. So.
I think we all did for a moment. I apologize for that. So
that's okay.
Please start again.
There we go.
Here you were. Thank you.
So here's the complex situation. Children's hospitals are asked to administer here. They say, here, children's hospitals give these monoclonal antibodies to children under this EUA, which is somewhat not experimental, but broad scale innovation. The goal is to prevent progression to severe illness. So there's an individual benefit there and a community one, right? Because it decreases utilization of healthcare resources. But the benefits and harms are unknown in children, and the EUA criteria seems to be broad and somewhat haphazard, at least in regards to children. And the infusions itself require significant resources and logistics, not only identifying the children, but bringing them in to give the infusion, but then monitoring during the infusion. And then, if parents are also positive, presents some barriers as well. So it's a big ask, very complex with some competing issues around that. And so here is the emergency use authorization, just to give you an idea of why it's so broad, 12 to 17 years of age, and have, BMI and the 85th, greater than 85th percentiles, not too broad, and sickle cells. But when you get down to congenital or acquired heart disease, there is a large spectrum of that fits into. And so, and furthermore, we really haven't seen children with congenital heart diseases getting all that ill with COVID overall. And neurodevelopmental disorders like cerebral palsy, these are also a very broad spectrum of disorders. And then medical related technology dependence is another broad, because having a gastrostomy might not put you at higher risk for progression to severe disease of COVID. Certainly a trach invented child might be, but again, we really haven't seen that as well in our kids. And then asthma, of course. So it kind of seems like to us that when we got this asked, that this was the typical list when people say, hey, what are compromised kids look like? And then it's just, here's a list of a general, but not really specific to COVID necessarily. And so it gave us some pause. And then there was also unclear guidance. The Infectious Disease Society of America and the Pediatric Infectious Disease Society recommended against routine use. So they did say that consideration in individual cases for high-risk patients, evidenced by pediatric specific data, but of course had no data for that, just said, pediatric specific data. And then again, who is, cases for high-risk patients? Really, what we've seen in the hospitals, at least in the first part of the pandemic, was obese teenagers. The National Institutes of Health made no recommendation for or against its use due to insufficient data. So none fully opposed. Some children's hospitals were not participating in this around the country. Some just said, there's no data, We don't know. It's going to take significant resources. We're just not going to do it. And then some did with some limitations on criteria. And the other issue that comes up here is race. And we have great data from a lot of good public health people, especially here in Minnesota, on the impacts of COVID-19 on as Black and Brown and Indigenous community members, particularly due to the structural racism and inequitable health already. So Bamlanivimab, which was actually already now pulled, they're no longer authorized to give that anymore. It just happened a couple of days ago. But as you can see here, the characteristics of the patients who were in the study, we've got a very small percentage were Black, and they actually reported no Indigenous population at all. And so, looking at sort of representation and studies, and considering that a lot of our patients are of that population, it's just one more thing where we have no data and no representation. Another one, Region CoV-2 study, also you can see had very low numbers in their total population for BIPOC individuals. And so here's what essentially the question was posed to children. It says, here's what we want you to do. Broadly offer an untested, I'm interpreting this for them, what they're asking us. Broadly offer an untested cloned cell medication intravenously to symptomatic COVID positive children in the state who are not necessarily all your patients. And so we won't have extensive history or physical, which was another issue, that these kids might be coming from outside areas where we don't really know their H&P. So what do we have to do? 2 infectious disease organizations advised against the standard use. Not only is there lack of data on children, but also on Black and Indigenous persons. The majority of children progressing to severe disease and fit the EUA are Black and Indigenous and persons of color. And their presumable COVID positive parents will be coming into the hospital with them. And we may only prevent 1 child from progressing to severe illness for every 100 treated. So the number needed to treat, so the number needed the treat to see an effect was about around 100 or so. So meaning out of that 100 infusions, you might get 1 prevention to severe illness out of it. And so in these situations, when I generally get involved in these kind of situations when nobody knows what the right thing to do is, they call the clinical ethicist. And of course, there's many different right things to do here. And when that comes up, I like to use a method that's sort of natural to me, which is sort of pragmatic reflection, clinical pragmatism. And it's essentially nothing special. It's just a method to, as you see, assess the relevant facts, diagnose the moral problems, consider the options, set goals, and negotiate a decision for an acceptable plan of action. And basically, a lot of my cases come to this because most people don't act unethically, but we all come to a situation with the best intentions, with just different ways of getting there and different values. And so sometimes when there isn't an exact right way, there is a least worst or a best way to go forward in context. And so that's kind of the approach I take here, and that leads us into the relevant fact, and then it'll get into how I went through this situation. So we have a drug for children with no trial data. So because it wasn't tested on anybody under 18, but then authorized for people 12 to 17. Number needed to treat for children is high. Must be given while patient is positive and within 10 days of onset. So there's a time constraint there. It's uses a high amount of resources. It's presumably high risk considering we don't have any data. If it was a research study, this would probably be considered greater than minimal. Possibly high benefit though for some. Some kids are progressing to severe illness, and we're actually seeing a little bit more of it now. And so it does potentially have a high benefit for some individuals. A disproportionate number of these children will be from communities who were targeted for unethical research in the past, as well as experiencing long-term abuse and racism. So there's, you can imagine trying to, here we have a benefit that benefits a population that already has bad experiences that we've essentially caused. And severe COVID disease is really bad, and we don't really know a whole lot here. So what do we do? So the moral problem here I came up with, on one hand, we have a benefit that could be very beneficial to some patients. Yes, we have a lack of data, but I think we can extrapolate 18 and above data to at least like 16, 17-year-olds and feel fairly comfortable with that. And those are some patients that are progressing to severe disease. However, there's concern that we might be causing a harm as well, right? We're giving we don't have data. The EUA is very broad. Are we going to be causing a harm? And so this gets into what's most notably is, beneficence and non-maleficence, right? Doing good and not doing harm. And furthermore, just on a institutional level, if we, on one hand, if we didn't offer it, we could be seen as withholding a benefit potentially from a child. On the other hand, we could be seen as experimenting, considering we're giving a medication with very little data to a population that has already been historically targeted, not just in racism, but unethical research. So there's two options here. So, it would be ethically supportable for a children's hospital to just choose not to participate. There's lack of data, huge use of resources, low number of children who would benefit. There's potential risk. But would this restrict some patients from benefiting? And is this a fair chance to prevent severe illness? Does this do justice? Especially if you have the societies speaking out, saying don't use it for routine use. You have plenty of reason not to. Also, but a children's hospital could choose to participate. And then if so, what obligations are present to meet these challenges? And to that, we want to set goals. And when we're progressing in a situation like this, where we're at risk of, we're trying not to do harm and we're trying to do good, the best thing to do is set goals and ask yourself, how should we act, and how would a good institution, organization, or profession act? So we want to look to virtue ethics, because we have a situation that could be harmful, but could be beneficial. And so the way to balance that generally looks at, like, what are we trying to accomplish? Who are we trying to be? And how do we make this happen and provide more towards the benefit and reduce the amount of harm? So these are these competing tensions, right? There's lack of a clear best solution. There's only a bunch of other different options that are sort of competing for a best. And so in this, we should proceed with the focus on our approach rather than the results. And I like this quote from a public health scholar, Dr. Meager. I saw that she wrote a paper, and then I saw a presentation of hers, and I've been thinking about trust for a long time. So when I saw this, it was like, it clicked with me. Whereas trust is a relationship of dependency, trustworthiness is often considered to be the commitments, virtues, traits, or features that ground justified or well-placed trust. And so, setting the goal of trustworthiness became sort of the clear goal in this situation. And this has really been something that I've been thinking about for a long time. And as a charge nurse, I used to say it, to my staff, is like, look, they don't have to trust us. We have the obligation to be trustworthiness. And that switch, I think, is important because it looks more towards what we're doing to be trustworthy instead of focusing on why people don't trust us. And these were two recent articles that came out that I just thought were just amazing because it exemplified that. And the one quote, "We believe it's time to shift the focus from a sole emphasis on changing hearts and minds among members of BIPOC communities to ensuring that institutions are trustworthy, transparent, and engaged with communities during the vaccine rollout." So specifically about that. And time is running short, and trustworthiness, not trust, must be our first and urgent priority. And so going forward with that, what does trustworthiness look like in this case of monoclonal antibodies? And really that gets down to transparency and equity, because by choosing to offer it, we're already choosing fairness and justice to say we're going to give some people this option. So how do we do that? Well, we have an obligation to be a protective barrier to innovative treatments, while at the same time equitably providing access to those innovative treatments, right? So we need to be both transparent and equitable. So that requires us to scrutinize the EUA, and if inappropriate or not rigorous enough, then we need to modify it. We have an obligation to look at our patients and figure out that if we feel it's inappropriate for that EUA, we need to look at what criteria then would we feel comfortable and meet trust with our population, and be transparent about that. Then once these conditions, the conditions eligible are agreed upon, it must be offered to all who meet that criteria. And what I mean about that is it can't be left to individual clinicians at the bedside. If they meet this criteria, it should then be offered to them and equitable time and information should be given to that family to make a decision on their own. Because it's such a high level of competing tension, you want to eliminate that risk of implicit bias in the individual encounter. And we need to be clear, so clinicians at the bedside need to be clear about the data or the lack thereof, be clear about the individual risk of progression to severe disease, and be clear about the benefits. And again, all children meeting eligibility criteria in our eligibility criteria should be offered it. And individual clinicians, that means cannot not offer it, right? And so the argument there that comes up is, are we violating, the right to autonomy of the provider to make an autonomous professional decision what's best for their patient? And sure, that is, we somewhat are, but that's balanced out by the need for justice and fairness and equity. Individual clinicians don't lose their obligations to the patient at all. They still need to offer informed opinions consistent with shared decision-making standards. So they have an obligation to offer this treatment and then talk with the family about whether they think it's good or not for this particular child. And then patient and parental autonomy still exists, where they have, informed of the risks and benefits, provided with all clinical recommendation, and then patients should be able to assent or dissent, and then they make the final decision. And of course, the parent or guardian has ultimate responsibility to consent unless it's a mature minor. And again, clinical obligations, I just kind of went over with discussion with family, provide individual clinical recommendations, and provide space and time for decisions. There is a short window, so parents need to know that, but not everybody can decide on the spot. So that needs to be allowed for in the process when it's designed. And so our experience followed this, just looking at the time. We had a general agreement at Children's Minnesota that the EUA was not adequately representing children at risk for severe progression. And this wasn't just Children's Minnesota. I'm on a number of other national groups, and there was some other children's hospitals around the country, some that did not offer it, some that made it on a case-by-case basis, that they would convene as a group of infectious disease physicians and decide whether this patient should get it or not. Another one changed criteria. And so we decided, though, that the EUA didn't adequately represent children at risk. We were concerned given the societal statements. And so we decided that it could benefit some patients. And since it didn't seem, one thought was, well, adults are getting more sick, maybe they need it more. Why should we even have this at all if the number needed to treat? It didn't seem to be the case. It wasn't a scarce resource at that time because the demand wasn't very high for it, I think, for all the reasons it being innovative. So we decided that we would offer it, but we needed to really go through with a clinical group and decide who really would gain benefit from it and minimize harm. So the benefit of it would override any potential harms from that. Who is this group of children? And that we could automate in our system and then send out to other pediatric providers in the community. So we actually ended up developing a collaboration with the two other centers, U of M and Mayo. And we had developed an extensive list with consensus between all three centers, which is an amazing feat on its own. A couple other places were not able to do that. And then we unified our statewide criteria. And so this was our consensus statement that the health department did put up. They reported it as a suggested clinical criteria designed to assist providers with clinical decision-making, was developed by an advisory group consisting of clinicians from Children's, Mayo, and the U of M in collaboration with the Department of Health. However, they say that the list does not supersede the current EUA eligibility. Oops. And so they were happy for the assistance, but they said, well, we're still going to use the state, the general EUA. So I think right now we're still in the process of what do we do with that information? Do we use our own specific or do we use the broad EUA? We're still kind of getting there, and I think there's still talks going there, so I won't talk to where we landed at. My ethical opinion would be yes, use the consensus clinical criteria that we developed, because we did it with putting the interests of kids first and decreasing harm and maximizing benefit. But in conclusion, when faced with a difficult balance between benefit and harm, and either action might be ethical, look inward to character. As an institution, group, or profession, this must be the ethic of trustworthiness, especially when you're providing something to a scared, frightened population in strange times and pandemic times. And I like the Albert Schweitzer quote of, the only way out of today's misery is for people to become worthy of each other's trust. And just one more. I just want to acknowledge the hard work of Dr. Christina Kutsari, who was our infectious disease pharmacist, who was tasked with this, what I called the impossible task of developing a process and criteria to infuse this drug for children with no data at all, which I think is just a monumental task. And also Dr. Samir Patel from Lurie Children's, who we worked on a manuscript that's coming out about this. And then this is a link to what I think is just a great, the ethic of trustworthiness in public health practice, which I think is a great talk, and I think something we should focus more on. And that's it.
Thank you so much, Dr. Wolfe. I think that we have someone who wanted to ask a question. So we'll go ahead and start with her.
Hi, Ian. Thanks so much for this talk. 2 questions for you. First of all, how does it factor in for you as an ethicist, but also as a clinician, parental desire to receive, therapies that might be a little more, let's call them cutting edge, or with less data behind them? And then second of all, how do you deal with the challenge if other institutions are providing these therapies and for example, Children's had decided not to? So yeah, two different ethical questions for you. Thank you for the talk. It was wonderful.
Yeah. So the parent one's interesting, and I think that's in anything when it's innovative, right? And there has to be, depending on the age of the child or the capacity of the child, assent or dissent. I mean, if it's a 16-year-old child, it's like, heck no, I don't want this, but parents are really pushing for it. I mean, that's generally when we sit down and try to figure out if we can't come to some sort of decision. But ultimately, I would respect the child's decision there. And I think it's our duty to really make sure we've really explained that's that transparency piece to parents of like, giving them the data, giving them our recommendations, and really explaining that there is no data in kids. And so like, this is a risk, and here are some of the risks. Now, the risks with monoclonal antibodies are not necessarily overwhelmingly like bad. I mean, they can be, and that's of course balanced with a benefit. And so if that benefit's not there, then I would really adequately explain that to parents. And that's why it was good with our criteria, because I felt like then we had met some obligation to kids by saying like, no, that broad criteria is it's too harmful to some. And so we will really hone that in. And to the question of other institutions, that was a problematic question, and one that I thought of, and we bring up in the paper, is that there is an issue of justice if you're the hospital that's not providing it, and then no other children's hospital is providing it. And so, it's a question that I think, especially with this pandemic, where there was so much things being allocated by the hospitals and the Department of Health. I think this is where we would have had to bring it back to the state and says, we don't want to do it because of this. We understand there might be a justice issue there now, because now nobody is going to get it, or is there another institution that would offer it to children? And that's why I think my personal opinion is, I don't discount people that chose not to offer it, like CHOP in Philadelphia didn't offer it, I believe. And I think the best path forward was one where we do offer it, but with rigorous work into the criteria, because I agree. I mean, I think a state could be fine saying it, because there's no data in 12 to 17-year-olds. So it's a little bizarre situation that we even were authorized to give it. So, but yeah, there's definitely a justice issue there.
Thank you. I just wanted to say one thing that really stood out for me at towards the beginning of your presentation, when you talked about moving from trust to trustworthiness, I really like putting that onus on the provider to be trustworthy rather than telling people that they should trust us when there's been so many examples of why they shouldn't trust us. And I think, that just kind of, I'm going to be thinking about this a lot because that kind of blew my mind. Like, oh, right, that's what I've been teaching students. But, when I teach nursing students, I would say the first time you don't tell the absolute truth to a patient is the last time they'll trust you. And that will further impact the way that they get care in the future. And I think that's a really important piece to know as a provider or a clinician and anyone working with people.
Yeah. And it would have been easy for us to just say, yeah, fine, EUA criteria, boom, go and done. But I think that's, another obligation of like, if we have this feeling that it's not appropriate, then we have an obligation. It would have been so much easier just to do it because there was significant amount of man hours put into this, or people hours Dr. Kusari was, I didn't envy her having to be so busy with this and this impossible task. This is a lot of thought, kids coming from outside clinics without their HMPs. What do we do? Parents coming in with positive status might not, might need their own. What do we do with that? How do we assist the providers at the bedside, with this sort of odd intervention that some might not be comfortable with? And so it was definitely a monumental task. And of course, I think as this group probably know, being trustworthy takes a lot of that work. And then, being transparent about that amount of work so people know, like, we aren't just giving you this willy-nilly, like government says, sure, give it, and we just throw it in. We're actually doing our duty to look at this to make sure it's really what's best.
That's great. And I think it's really good to be looking or being informed about the process that you've been using to get to your answers. Have there been, that since there's other now studies going on with kids, have you been involved with some of the other things with COVID, looking at the ethics around the vaccinations or anything in that area that you can talk about?
Yeah, we've been involved, ethics has been involved in sort of the vaccine allocation, and that's obviously, I think, we sort of echo the sentiments that a lot of the bioethicists and physicians and nurses and public health professionals around the area have been saying, which is, trying to balance this desire to speed it up with equity, and those two things are not generally compatible, at least in our current, in the current state of the country and in our state. So that's been tough. And I think, it takes a lot of pushing to get people to really invest this time. And we did get an equitable vaccine group together and spent a lot of time trying to figure out, because it's so easy, right? Like these processes are systematic, where they're generally set up, the path of least resistance is set up to create inequity. So you really have to jump in and stop those processes. Like even when you have empty or a leftover vaccine at the end of the day, it was so easy to just, call up your neighbor that you knew. And of course, our vaccine people had everybody, around the hospital texting them like, hey, if you got any extra doses, my neighbor is so-and-so. And so, it took extra time to like walk around the hospital and find some of the, evening or night shift staff that don't check their email a lot and make sure they got vaccinated, or having a system set up so we could provide more equitably for people that are more at risk for severe progression versus those who, have the privilege to be able to self-quarantine easier and aren't as at risk. So, and as you well know from reading the news and hearing it, the state in itself didn't do as good as we could have, probably, for sure. But
yeah, it's been a process, and unfortunately, or in some ways, it's good that these inequities are revealed so that we can be working on them. But it's hard to be in 2021 and realize that there's so many systemic inequities that are still in place and that are really affecting the people that we work with. And I think that that's been that's a tough one. That's something that we really need to be working on, striving for. And I think that then having, working on an anti-racism and being anti-racist, hopefully helps us move towards dismantling the systems, or that path of least resistance that leads to the inequities, the easy ways that we are inequitable that we don't think about every day. Yeah, are there any other questions? Kristen.
Hi, thank you so much for the presentation, Dr. Wolfe. I was wondering if you could speak a little bit to how you might approach a conversation with a family whose child or family member may not, I guess, qualify for a treatment like this, but they've heard about it, while still being able to, maintain and establish that feeling of trust between the family and the provider.
Yeah, I mean, that's a good question. And I think that's why having such a good consensus statement between all the hospitals is really important, because, would we be okay just if the parents demanded it, giving it to them? And we do that in a lot of treatments where parents demand things, we give it, but that doesn't mean we should or, must. And so, I would really go through some of the data and the conditions and our process around why we've chosen this way, and the lack of data, essentially, and the number needed to treat, and just really kind of spend the time to go through this with them. And then that gets into this is sort of where you need to really put this into your policy, because you have to sort of ahead of time, are we going to do this if parents demand it? And I think focusing on, well, what's your goal there, right? Our goal is for the child first. And if we're building this criteria on the interest of balancing harm and benefit to children, then you have to stay with that. But then your obligation changes to helping the family member go through and listening to them and seeing what their reasons are. I mean, maybe, I would, my opinion would be to put in a disclaimer on this sort of thing and say, well, individual cases can be assessed individually. Guidance is guidance, and there can be a little bit of leeway here and there. But really going through why we made this decision and why we did it. And that's not out of one of restriction, it's one out of concern for harm, or at least just not benefit the child. And it's about time and, giving them space to hear it.
Thank you. Yeah, it sounds like it would be an incredibly tough position to be in too, if there aren't other clinics that are providing it that you could, send them to, or other clinics that have the same policy to explaining that.
Yeah.
Definitely don't envy y'all.
And it would be easy just to infuse the kid for us, right?
Yeah.
But when it comes out now, a ban is taken off, so they're not authorizing it anymore. So it's then you run the risk of man, why did you let me argue for this and give my kid this drug? And now it's all these, big side effects down the way. It's so, I mean, we have that obligation to sort of say no and understand the fears out there of people that are coming in scared of the illness or the virus.
Thank you.
Yeah, thanks again. I think that we'll go ahead and end the session. Really, thank you so much, Dr. Wolfe. You've brought so many important issues and ideas here that I think will be helpful to all of us. And I believe, and we'll have this recording available for people to watch later. And yeah, I think that's it. Let's, give a round of applause sort of in our cameras.
Thanks, everybody. I really appreciate you coming to the talk.
Thank you.
And thank you for all your work as public health professionals. We need more of you, and we need to value you guys more. So
thank you.